apart from the fact that if anyone saw on the first slide, his platelet count was 800 and his hemoglobin was 11. So he was managed in the usual way, and 2 weeks in, the platelet count is 1200 and a hematology consult was called. And of course, hindsight is 2020, so when the hematologists came in, they said, but this is highly suspicious of a myeloproliferative neoplasm, irrespective of how the stroke looked. And so a little bit of digging deep into his previous stroke, which was managed outside, revealed that he had had a normocytic anemia and thrombocytosis previously. And so we decided to investigate him by mutational analysis. By this time, the platelet count was 1,200. He was on dual antiplatelet agents. It was felt that the bone marrow might be too risky for bleeding because of acquired von Willebrand syndrome, which happens when your platelets are too high and you break down the monomers that prevent bleeding. And so we decided to cytoreduce him, first of all, and do the bone marrow later while waiting on the mutational analysis. So JAK2 mutation positive. Eventually, the bone marrow showed features in keeping with essential thrombocythemia. And so we were happy that we were on the right track. This gentleman's course happened not to be very easy because the hematologist's enthusiasm in getting the platelets down meant we overshot terribly. He ended up pancytopenic for 2 weeks, gram-negative bacteremia, required platelet transfusions before he recovered again and remains very well in the community on only 500 milligrams of hydroxyurea on alternate days. So why am I showing this? This is a 73-year-old man with clearly atherosclerosis, metabolic syndrome, clearly proper risk factors for a stroke. But he also had anemia and thrombocytosis and a diagnosis of essential thrombocythemia. And when we risk stratify him, he sits right here in the high-risk group with a 4%, up to a 4% risk of thrombosis every year. So this changes this man's outcome from just requiring antiplatelet agents and everything else he needs to long-term hydroxyurea in addition to the treatment. So this is making us think the story doesn't have to end where you found it if there are other factors that are telling a different story. It's basically the blood is not lying to you. Keep looking at the blood. I'll tell you a different story of a 55-year-old man. He comes to the clinic with a progressive tiredness over the course of the month. He also says he's had some sort of difficulty recalling new words. And he's not low in mood, but he's wanting to be a loner. He doesn't want to socialize. And also when he stands up, he feels like he has to steady himself. There are no GI symptoms or dietary intolerance, but he has managed to lose 10 kilos by diet control. Only men seem to be able to do that. So in his past medical history, which was important, he tells me that a year exactly ago, he had a left carotid artery thrombus and ischemic stroke. And at that time, he'd presented with dizziness and vertigo and had a complete neurological recovery. He was only on Lipitor following that stroke because they had found a 50% carotid stenosis. And he has a family history of hypertension in his father. On clinical examination, the only thing to see was thinning of the hair and a rash on his back. So the reason he was referred to me is because the doctor who was looking after him found a severe anemia, well, moderate anemia, which was macrocytic, and they had investigated him appropriately and found him to have a very low vitamin B12 of 74, and if you cannot see that, the reference range is 150 to 900. So I thought, okay, this is going to be pernicious anemia. But I was interested to see what the previous blood test showed. So this is September 2018. My pointer isn't exactly working, but I can go close to the screen. So this is September 2018, and I think the CBC looks completely quite normal, apart from, I don't know, the red cell distribution width is abnormal. It's high. Red cell distribution width, it stands for your red cells are supposed to be normocytic, normochromic. They're supposed to be very monotonous. If your red cell distribution width is high, it means that you have different sizes of red cells. Why do you have different sizes of red cells? Not sure. This is when he presented with a stroke. And now you can see, even if the hemoglobin and white cells are completely normal, it's quite macrocytic, okay? So that's interesting. And also, the red cell distribution width is still out with normal. And now the RBCs are low. Why are the RBCs low? The red blood cells low. We'll come to that later. Then when he comes to see me, he's got a full-blown macrocytic anemia, very low RBC, RDW is still high, and as we said, he has a very low vitamin B12. So, no prizes for guessing. We did intrinsic factor and parietal cell antibodies, which are positive, clinching a diagnosis of pernicious anemia. But the only other test we did was, anyone? Homocysteine level. Okay? Because remember, this is a 55-year-old man, no prior history. He has a thrombus in his carotid artery. He has a lacuna infarct, which clears. I'm not sure about the 50% stenosis of the carotid artery. So I'm like, what are the chances that a year ago it was homocysteine causing this thrombosis? So his homocysteine level is 200, where the normal is 5 to 15, okay? So a little bit of biology. Remember, vitamin B12 is a cofactor for these two processes, converting methyl malonic acid to succinyl coenzyme A and converting homocysteine to methionine, okay? That means if your vitamin B12 is low, you're going to have too much MMA and too much homocysteine. That's why when you have a reference limit like we do of 150 to 900, whenever I have a patient with these vague symptoms, I'm tired, I'm dizzy, I'm this, and I do a B12 and it's 350, I'm not sure it's normal, even if the low end of normal is 150. And if you have enough money and you have enough time, you can do your methylmalonic acid and homocysteine levels because they are a surrogate for what available B12 there is and whether these symptoms are because of effective low B12. So that's a by the by, but the two of them accumulate in B12 deficiency. And while MMA is quite benign, your homocysteine is not benign. So it causes both venous and arterial thrombosis. From the venous side, it reduces the availability of your natural anticoagulants, protein C, protein S, and antithrombin. It increases factor 12, which we all know starts off the intrinsic pathway of coagulation. It also increases thromboxane A, which is an avid activator of platelets. It causes impaired repair of endothelium. And we know when the endothelium is disrupted, we get tissue factor, we get a prothrombotic state. So homocystinemia, hyperhomocystinemia causes venous thrombosis, but it also causes arterial thrombosis by interfering with vascular smooth muscle proliferation, LDL, and reactive oxygen species. So we have a guy who's been referred to me because it looks like he's got pernicious anemia. He does, but also he's prothrombotic because of hypercystinemia. So this is just saying to us, the blood has a lot to tell us, but we need to take a moment to look at it. I think my little bit on AI, Andrew. AI in hematology, I think when my patients come from other countries, they're coming with blood forms that look like this. So they are color-coded, and they help you when you see somebody's hemoglobin is 12 and the MCV is 79. Take another thought about it. If they're a menstruating woman, should we be proactively putting her on iron, you know? If somebody has got all these pseudoneurological symptoms and their B12 is 299, they might be B12 deficient. So I love hematology because pattern recognition, investigation, finding things out. But our version of AI is just look at it, see if it's telling you something rather than the obvious numbers. And, okay, I see you laughing there. But I had to look at what else is going on in AI in hematology. And I think the future looks like reducing for us. It's increasing diagnosis through easy measures, okay? So this is a study that's been published just this year in Nature, and it's promising because there's a technology that is being developed that using, it's called a transformer-based model and peripheral blood films. It has quite a high specificity and sensitivity for detecting some hematological malignancies without the use of a bone marrow test. And I think if you can convince hematologists, if such a procedure is validated and you can convince hematologists that the bone marrow test is not recommended, then for an environment such as ours, it would be a good future to be able to diagnose our patients easily, without pain, and give them treatment quickly. So, my take-home message is, we are all hematologists. The blood never lies. There are patterns, we need to see them. We need to see them coming as well. Look at those CBCs, look at the patterns in the red cell indices. Pick up the phone and call your friendly hematologist, and let's help manage our patients better. Thank you.
Thank you, Anne. I think this was pretty interesting, and we have all gotten into us that a simple thing like a hemogram, just a full hemogram can tell us a lot and can change the management of the patient entirely. So we still continue with Anne, with cardio-oncology. So you can take 2 deep breaths because we are running short of time.
Oh, okay,
and continue.
Okay. I'll go as
Thank
quickly as I can. So this will be less cerebral because I'm not a topic expert. And this time I managed to get the slides in the format. So really, why do we need cardio-oncology? The first thing to recognize is the advances that have been made in development of treatments for cancers over the decades, in fact, centuries. 3000 BC to around 1900, the mainstay of oncology was surgical resection. The first targeted therapy was in 1890 when Dr. George Beatson was able to show that when he removed ovaries from women with breast cancer, they improved. In the 1900s, we had radiotherapy, and then 1940s is when we had our anthracyclines developed, drugs that we still use now. So for a long time, it was radiotherapy and basic chemotherapy that we were giving our patients, and we were able to see over a period of time the standardized cardiotoxicity we get and manage it. But since the 1980s, I think the first targeted therapy was Herceptin, estrogen receptor, but the first monoclonal antibody, that was in the 70s, was in the 1980s, trastuzumab, and then that brought a new era of cardiotoxicity and got the cardiologists looking up. Since then, we've had tyrosine kinase inhibitors, we've got immunotherapy, we've got proteasome inhibitors, we've got immunomodulators, we've got antibody drug conjugates, where an antibody is bound to a drug for additional cytotoxic effect. We've got checkpoint inhibitors, not to forget cellular therapies, which is stem cell transplant, and CAR T therapies. And you can bet that all these therapies come with their complications. So where we've moved from, basic treatment of patients, we've now got patients living longer overall survival, longer progression-free survival, but with more cardiac toxicity, and also patients who already have a poor cardiac profile, metabolic syndrome, living to get cancers, and also not forgetting that there are some cancers that manifest in the heart, neuroendocrine, amyloid, to name but a few. So in the past, it was chemotherapy and radiotherapy, and in the case of anthracyclines, let's say you have a profile, you want to check the patient's age, you want to check their metabolic profile, you want to do an echo and determine whether you'll give them the anthracycline, or omit it, or give them a reduced dose, or give them something different, okay? And it was pretty straightforward and basic. But this is what it looks like now, We got to realize that our old drugs also cause valvular disease, they cause arrhythmia, they cause atherosclerosis. Our new drugs, cardiomyopathies and itis that can be fatal within a very short time, they cause pericardial disease and myocardial infarction. And the thing is, unlike your anthracyclines where you could be predictive, you can do patient's profile and say, he's fit for an anthracycline, I need to reduce the dose, or is it? For some of these drugs, it's a little idiosyncratic. So you can't really predict who is going to have a poor response. Cardiologists don't have enough information to know how to manage the patient optimally. So this is where the birth of cardio-oncology came from. And quickly share one of our cases, simple myeloma. You can see there was hemoglobin 7, creatinine 100, 90% bone marrow infiltrate. That's my shaky hand on the microscope, but those are all plasma cells. Started him on first-line therapy, but he had the most severe GI side effects, so we had to abandon. Switched him to second line with carfilzomib-based therapy. And this therapy is given on day 1, 2, for the first week, day 9, the second week, day 15, 16, third week. So he did day 1, day 2, and then day 8. And he was very, very good. When he came in for day 9, he knocked on my clinic door while I'm seeing another patient. Doc, I'm just going in for treatment, but I want to tell you that yesterday on the way home, I had this heaviness on my chest that I couldn't seem to shift. I took paracetamol, I took diclofenac. I think it went away at 4 a.m. So obviously, I told them not to give him his treatment, sent him to have an ECG, which was normal, but his troponin was high, and his proBNP was very high. So I called a friendly cardiologist who admitted him, did an angio, and I can tell you that it looks like very normal coronary artery. Which is also what they summarized. The echocard systolic ejection fraction and hypokinesis in the inferior and inferolateral walls. And it was concluded that there was no significant coronary artery abnormality of note, and could there be myocardial spasm or myocarditis? We weren't sure. So what do you think I had to do? Well, first of all, to tell you a little bit about carfilzomib, it's a proteasome inhibitor. It's been around for about 14 years. It has very good outcomes in most patients, but this study in 2023 was able to show that it's associated with cardiac toxicity in 7 to 27% of cases, which is what we know and what we warn our patients about. But there is no proper way of screening for this, okay? And it's just, you think of a drug that came out 14 years ago, and we're coming up with protocols for screening and following up the patients in 2023, kind of almost 10 years later. So the cardio-oncology was like kind of crawling on its feet, getting to where it needs to go quite slowly. So what should we do next for this patient? Should we continue carfilzomib? So, no. And luckily for us, we have an armamentarium of drugs we can choose from for the next line. So we stopped the carfilzomib, switched him to another regime, gave him a transplant. He's now 69 and he continues to do well, and he has no cardiac complications. Okay? So I'm going to rush through my slides, but I think what I'm trying to demonstrate is in the old days, you could have cardiac toxicity noted by many doctors, and then we kind of establish how we are going to do it, and you have time to observe the patients and titrate. But we're in a space now where there are so many drugs being developed that there is no time to catch up with what the toxicity means and how to handle it. We have a joke with, or we used to have a joke with our cardiologists whenever a patient had a drug and had a very high troponin, and we used to say this is not a heart attack, and we used to call it a troponinitis, but need an angio for cure, because the troponin is high, cardiology says you need an angio, but it's a drug reaction. And again, just to say, it's taken 10 years to get a risk-mitigation profile for carfilzomib and a plan for these patients. So the reason we need cardio-oncology is to be able to have a concentrated group of people who are able to concentrate on, these are the drugs, this is what they're doing to the patients. Can we sideline and organize ourselves and plan, this is how we're going to risk stratify what kind of patients they get these drugs, this is going to record how they're responding, what the reactions are, because this is a new specialty, and I think our patients may then be different from the patients elsewhere. This chart just says there are many strategies which include our conventional cardiac health, as well as drug strategies. I'm going to go quick fast because of time. And this is only illustrating how the need for cardio-oncology evolved at the MD Anderson Center with one cardiologist back in the 90s, and we have 14 cardiologists in the cancer center treating cardio-oncology. So this is my second last slide. I think I've gone very fast, but trying to put the argument for we need a concerted effort to look at our patients, to be able to record what responses they're getting to drugs, to be able to make protocols that are responsive to our patients. We need to study, we need to learn, we need to share this information. Some Africa is already doing it. Ghana, not yet in an organization, but certainly South Africa has the Cardio-Oncology Society of South Africa, and they hosted the Cardio-Oncology Summit last year. So what we're looking towards is a cardio-oncology working group, which will be collaborative between KAP, and Cardiac Society, in order to build a database of our patients, to record their responses to, and to be able to share our information with Africa and outside, and then to chart the future in cardiology for Kent. Thank you. I had to run. I hope it's okay. Sorry, Dr. Kasmani.
Thank you, Dr. Tari, for rushing that. We appreciate it. So we are now going to swing onto infectious disease. We are privileged to have Professor Rodney Adam from AKU University Hospital. He's an infectious disease specialist there, and very interesting and detailed in the way he presents. So we are looking forward to, which is on update on respiratory, STI, GI infections, seen by syndromic CR. Very good, Dr. Tari.
Well, thank you for giving me the opportunity to speak here. This is not an AI talk. However, AI was very useful in reading the script to use our extract and analyze data. So even there, I guess AI comes into the picture. This is sort of the background, a pre-COVID display, and you see following this will have some interesting contrasts. We did a prospective study, looked at viral causes of pneumonia, and had a couple months short in March of 20. Guess what happened then? First case. And there were a total of 77 patients enrolled in that study, and for a one-year period of time, it was using a panel that we weren't doing clinically in the lab. It was done for research purpose. So the background from not long ago, then COVID came, and then during post-COVID is really when we had a recognition of the importance of some of these syndromic tests. So here's a list of what's probably the major syndromes to be tested. The GI BioFire is a very useful test. There's been all of the BioFire tests about the cost, even that debate in the US, but they do contribute significantly, and I'll go through a little bit of what that helps understand. Meningoencephalitis, again, it's very useful to have that broad range test. Sexually transmitted infections, you actually have several syndromes to look at there, and the one where we especially counted is urethritis. And I'll give a quick overview of that. And then respiratory infections, again, with the focus on there we're actually using two different panels, and I will compare and contrast them. Great. So starting with the BioFire, first of all, this is percent positivity for tests. Most of these that I'm going to demonstrate are percent positivity. We've also done the same analysis with total number positive. This is probably a better representation, and we don't have time to do in parallel. The top one that you see with the large number of positives, the EPEC, most of the time that is instant. But let's move down below that. Might be surprised to see that, and this is primarily for hospitalized patients, norovirus and rotavirus are the most common pathogens, even in the setting where we see a lot of the bacterial pathogens. But then we see the whole array here. Clostridium difficile is relatively common in terms of PCR detection. It's very different from what I'm used to seeing when I was in the US. There, don't know if it would have been as common, but the cases there were much more severe than anything that we have seen here. Going through, I'll comment on Vibrio cholera, and I'll show a data display on that. It tends to be outside. Notice how rare Entomoeba is. It's a very fine. And part of the contrast between that and stool microscopy will pick up a related species into MISPAR, which is a non-pathogen. So that's a marked difference. Now let's look at a few of the data slides. Sapovirus is one that we don't talk about a lot, but it's moderately common in this setting. I can see what people are struggling with this, probably all the range. Virus, you see there's some variation across time, the clear seasonality to it though. It has peaked as high as 30% sensitivity rate. Norovirus has been 40, but again, you see that sometimes the positivity rate is very high. That's noted for Crucia gastroenteritis. Here we see it as a steady pattern coming in. Now, Vibrio cholera, notice we had one, looks like outbreak session back in early 2023, and after it has been episodic. But it'll be to see what we find now after this current season. So lessons from the BioFire. I already mentioned the EPEC that mostly can be ignored. Virus and norovirus are leaders in terms of numbers. And I'm going to just hone in on the histolytic. For some reason, it seems that everybody in the emergency room comes out with quinolone plus metronidazole. Metronidazole has no role in empiric treatment of gastroenteritis. So keep that in mind. I think at Aga Khan, our casualty and our residents are doing that somewhat. Now, to meningitis, this is a total of 365 tests over a period of about 3 years. So it's a fairly high percentage of those with suspected infectious etiology for a CNS problem. Now the HHV6, human herpes virus 6, that's the top one, a very common finding. And the literature and the feedback from the clinical side is that most of the time this is an incidental. It is a pathogen in especially stem cell bone transplant, but most of the time when you find it here, it's an incidental finding. Notice the Neisseria meningitis, which is one case, but that's interesting. Kenya has been on the meningococcal bile list, and yet I think that is the first invasive meningococcal infection we've had at Aga Khan years. So it's an extremely rare one. Also at herpes simplex virus 1, when I joined, it seemed almost everybody went into CNS in a presentation was reasonably severe. For most patients, that is not necessary. So I've heard these major ISMV is, according to the literature and prior data that we've looked at, almost exclusively HIV related. There's no other kind of patient. And then one little trivia, antigen detection is actually better than PCR for cryptococcosis. I think it's the only one I know of where antigen detection is better than PCR. For STI, and this is urethritis cervicitis, the test that we're using has a total of 7 isms, and them are grayed out here. We don't report them, and I'll go through a little of the rationale why and why that's going to make a difference in the lab's choices. Emmetoplasma hominis and ureaplasma parvum. Here is the all 7 of them. Looking at the total numbers, I'll show others with percent positivity, but notice that these 2 that I mentioned, the ureaplasma parvum and the emmetoplasma hominis, are very commonly found in these tests. So there is a significance if you actually report them. There we go. So a little bit of history on these organisms. The 1970s, Chlamydia trachomatis was recognized as a major cause of non-gonococcal arthritis and post-gonococcal urethritis. And then there's the issue of the genital mesmas and their association with arthritis. And that is an evolving field, really, for about the 30s. The mesmas first divided into 2 genera, ureaplasmas and mycosmas. And then to ureaplasma parvum and ureolyticum were subspecies. Same thing happened with mycoplasma, with genitalium, and with hominis. Now, when we look at those 4 different species, ureaplasma ureolyticum is probably a pathogen. Mycoplasma genitalium, yes, and it's very similar to chlamydia trachomatis in terms of the clinical manifestations. The others are not known to be pathogens. And there are tests out there that do distinguish one species from the other. So I got a thing called from under the gynecology. Now, what do I do? This person treated again and again for ureaplasma, and it was combining all of these, and hopefully didn't need to be treated. Now here, we're percent positivity, and we're only looking at the 5 organisms that we actually report. It's been very interesting in trying to figure out the significance. So first, to the left, we have a male ratio of about 2.5 for chlamydia. For mycoplasma genitalium, it's about 3 to 1. For Neisseria gonorrhea, it's more than 5 to 1. So it's for each of these, it's a male predominance, and that is different from what we see in the literature. And we'll say we don't have a good explanation for it yet. Trichomonas is not a very common finding, and especially in males, where it's only 2% positivity. But the initial attempt to get out this male predominance to say, well, in some special group that is coming to one or another setting. But in fact, if we look at Neisseria gonorrhea, the AKU, mainly AKU, emerging, of course, G1 friends, Rift Valley, they're all similar. So it's not limited to one particular patient area. Can't explain that, but any of you have to let us know. Co-infection rates, we all hear about it for chlamydia and gonorrhea. You see similar rates of co-infection with some of these other pathogen combinations. So lessons from the STI panel. We've talked about for each of these. So now the respiratory biofire. and it looks like we're going to see that same peak. That's interesting because in the literature, the tropics are said to not have seasonality. But now we have at least 3 and maybe 4 years running where there is a seasonality. And RSV in the north, US and Europe and Canada, RSV and influenza peak about the same time of the year. And if you look here, apart from that early peak, the end of 2022, you see the same kind of peaking with RSV. So it looks like we have a pattern with a March peak for influenza and RSV. That's just influenza A, by the way. Here are the biofire-specific pathogens, and so we've had looking for some of the others than the biofire is very useful as well. Okay, adenovirus, rhinovirus, that's always going to be a common one. It can cause lower respiratory tract disease, but doesn't do so often. Parainfluenza, the major agent of croup. Metapneumovirus, which is similar to RSV, but focuses on a slightly older child. So lessons from here are mostly about influenza A and RSV that co-circulate and have a peak right around March. So thank you very much. I think I made it within time.
Thank you very much for that. So we want to go on with the last talk for this evening. And I would like to invite Dr. Charles Koba, who's going to give us a talk on experience implementing a multiplex PCR platform and the role of BioFire. So Dr. Charles Koba is a consultant physician and an assistant lecturer at MTRH. Karibu Daktari.
Okay, so I think as we wait for the slides to load, thank you. I want to say thank you to KAP for inviting me to give this talk. And coming right after Prof. Rodney has given their perspective from the private sector, I'm going to share our experience from a typical public sector. So we've had BioFire at MTRH for about 5 years now. Sorry, I think this is not really working. I don't know if you can help me to move the slides. Yeah, I don't have any conflict of interest to declare. Prior to presentation, and she presented to us with complaints of inability to talk, difficulty in walking, and confusion, which progressed to coma over about a week. Clinical assessment basically was concerning for meningoencephalitis, and so we proceeded to do the evaluation. You can see on the left side she had obvious signs of meningitis. We did a number of labs and imaging. The CBC UECs were unremarkable. Her ESR was elevated, as well as the CRP. The serum CRAG was negative. BS was negative. CD4 count and viral load were not available at this point. and her brain CT was unremarkable. So we proceeded to do a CSF analysis, and you can see from the left panel, we have the biochemistry there. The glucose was low, the protein was elevated. These are usually, we would think about either bacterial or mycobacterial infections based on this biochemistry. But in this case, the gene expert for MTB was negative. As I said, the CRAG was negative, the cultures were negative, and we ended up running this sample on the multiplex PCR biofire, and we were able to diagnose this patient with CMV. We think that it fits given the HIV infection and just having initiated antiretroviral therapy recently. So this brings us to the definitions. Basically, a syndrome is a set of signs and symptoms that usually occur together. And therefore, syndromic testing means that it's a process of using one test to simultaneously target multiple pathogens with overlapping signs and symptoms. So the idea is that you have one sample, you do one comprehensive test on that sample, and usually it is a rapid test, so usually you get results within 1 hour, and within one report you can get multiple results. And so why did we think that it would be important for us to roll out multiplex PCR at MTRH? Of course, the traditional tools that we have, they are time consuming. You usually identify one pathogen at a time. And previous data in our setting had shown that up to 40% of patients with syndrome of meningoencephalitis, we did not know the etiology. So we wanted to see, are there things that we are missing, and what could these infections be? Obviously, again, the traditional tools have poor sensitivity, especially in the case of viral etiologies. So we introduced this panel-based test, and to the best of our knowledge, is the first one in a public sector in the country. And some of the benefits that we anticipated, of course, includes improving diagnostic stewardship, reducing time to diagnosis, and hopefully initiating early appropriate treatment for our patients. So that is just the principle that is applied in multiplex PCR. On the left there is the tool. That's the way it looks, like a printer. That is basically a tabletop kind of tool. And so these strains represents the different infections that might be present in the sample. And basically you have primers for each. And so within one drop of CSF, for example, when you add the primers for all the possible pathogens, then they are going to be detected using just one run of the PCR. So it has several advantages, including rapid and accurate diagnosis of infections. It is quick. It can detect fastidious organisms that are difficult to culture. And obviously, it will have also implication on the length of stay for the patients. The challenges in our setting, the cost can be prohibitive because one test, when we started, was going for around 40,000. Very high sensitivity, so sometimes it picks more than one organism, and you're not even sure which one is the one causing symptoms, and I'm going to show the data. And therefore, the interpretation is very, very important, especially in the era of antimicrobial resistance and stewardship, where we want to salvage our antibiotics. This is the panel. It is able to detect several bacteria, including E. coli, Haemophilus, strep, and Neisseria. Several viruses there, and the fungi here is Cryptococcus. What is missing, and I think we've discussed this with the manufacturers, we hope that they'll be able to develop a TB element as well, so that it can be more comprehensive. So it means that you have to do your TB gene expert separately when you are using the multiplex PCR. So in terms of performance of this tool for CSF, basically you need a very small sample. 0.2 mils of CSF is adequate. And even if the patient had initiated on antibiotics, it still tends to have a higher diagnostic yield than your typical cultures. And in terms of the lab, for the techs, not much pipetting is required. It has a rapid turnaround time. And I've talked about the duality, where it can detect more than one pathogen at a time. We have minimal experience with the respiratory panel. I'm not going to share the data, but we ran a short series in the pediatric outpatient clinic where we enrolled 36 children between ages of 5 to 14. And we did basically nasopharyngeal swabs for these patients. And out of 36 of these children, we found 10% had a positive yield. And out of these 10, we had 5 cases of RSV and 5 of human metapneumovirus. So that was we just wanted to pilot it and see the common infections that occur in these children. Of course, the pediatricians will know what to do with those isolates, especially RSV in the pediatric population. So for the purpose of this talk, I'm going to share mostly data from our CSF. And so this is our experience from the last 5 years at MTRH, and we have done nearly 1,000 CSF samples. We're at 930 at the time of this presentation. And as you can see from this graph, the most common isolate here is crypto, followed closely by HHV6, and then there's CMV and VZV. As you can see from our data, we don't have any case of Neisseria meningitidis, which is similar to what Prof had presented. For the first time, we are able to see Listeria. I think most microbiologists say that Listeria is not there in Kenya, but with this tool, we're able to pick one case of Listeria. So again, as we look at this data, some of the questions that come up and what Prof had discussed, which is the true pathogen and which one is not. In this case, HHV6 seems to be very common, but we don't really think that it should be given a lot of attention. So in summary, we have mostly viral etiologies, 56% being identified by this tool, then bacterial and fungal, rather fungal and then bacterial in that order. So I think the strength really for BioFire in our setting is to be able to diagnose these viral etiologies that would have missed without this tool. So one of the challenges of BioFire, as we said, it can be able to detect several pathogens within the specimen. So from CSF, we have a number of patients, totaling 24, who had more than one isolate in the CSF. So one with crypto plus CMV, usually in HIV infection, that is expected. You can have crypto plus varicella zoster. But then you start seeing this HHV6 that is co-occurring with many other infections. And those are the ones that we think may not really be important. So we need to be able to tease out and say from a patient with symptoms of meningitis, if you have more than one pathogen, are they all responsible for the illness or not? If you're seeing HHV6, probably it is not relevant, and therefore you need to focus on the pathogen that is most likely causing symptoms. Yeah, I think I'll not belabor HHV6 because Prof went ahead and discussed it quite well. And outside hematopoietic stem cell transplant, we don't think that the immune suppression in HIV is significant enough to cause HIV meningoencephalitis. So even if the patient is HIV infected, we tend to look for other causes. And in this series, we could see majority of the patients actually either had crypto, CMV, or other explanation for why they're having meningitis apart from HHV6. So there was a nested study by one of our registrars who now broadly looked at etiology of meningitis in this setting, and she did a full battery of tests beyond the biofire. So it included the antigen tests, GeneXpert, and everything else. And we have a series of about 94 patients who are recruited in this study. And of note, majority of our patients are HIV infected. Over 80% of patients with meningitis in our setting are actually HIV infected. Majority, more than 50%, have been exposed to antibiotics before the LP, and some of them have also been on anti-TBs. So from this study, we were able to move our positivity rate. Remember I said earlier on, before we started using biofire, that more than 40% of our patients with meningitis had an identified etiology. But with this and combination of all the tools that are available, we are able to move that positivity rate of 74%, and therefore our unidentified etiology has come down to 22%. One would then ask, what are these 22% that we are still not able to identify with all these tools? And I think that is still an open question. There could be other infectious etiologies. There could be autoimmune encephalitis that mimics meningitis, and many other things. So I think that is still an area of research to try and find out what these 22% represent. So from this study, again, you can see the most common cause of meningitis was crypto, followed closely by TB. So if you combine those two, you already have 55%. So 55% and above of our patients being HIV infected, the most common is crypto and TB. And then CMV and VZV follow closely. So again, before availability of this tool, whenever we thought about a patient having viral meningitis, the instinct was always to think it is HSV. And similarly, patients used to get acyclovir. But now we do realize that HSV is not as common in our setting as we had actually thought. And therefore, previously, our hospital never even used to stock ganciclovir. But once we had this information, now we are able to stock ganciclovir and get them the right treatment. So based on this data, nearly 1,000 samples, we have tried to come up with testing algorithms that can help us have a good cost-benefit ratio. Because given the cost of the test, and given that we have antigen tests for crypto that are very sensitive, but and at the same time quite affordable and cheap, so we think that we shouldn't utilize this tool specifically to diagnose crypto, because we have better and simpler, cheaper tools. So we came up with this algorithm where we look at patients either as pediatric or adult. Generally, in our pediatrics, the HIV rates are not very high. I think the PMTCT is working very well, so it's not a big problem in that population. But if you look at the adult population over 13 years, our testing algorithm recommends that one must do a HIV status first, and then if the patient is HIV positive, we suggest doing a serum CRAG, or rather performing the CSF CRAG upfront. And if that CRAG is positive, then we do report the result. For those with CRAG negative are the ones that then will proceed to do the biofire. For those who are HIV negative, they can go straight on to biofire. And this will reduce the number of patients or samples that have to be exposed to biofire, therefore reducing the cost of operations. But it has some challenges. So if you look at all these 930 CSF cases, if we follow this algorithm, we would miss 3 cases of viral meningoencephalitis. These were patients who are co-infected with crypto, because following this algorithm, would go down, run the CSF CRAG, and stop there, report the results as crypto, yet these 3 cases were co-infected with the viruses. So is that a fair cost-to-benefit ratio? I think it's an open question, and as we continue to smoothen our algorithm, those are some of the things that we'll need to think about, how we can go about it. So in terms of AI, we are currently working on a digital clinical decision tool that will incorporate some of these algorithms as well as other guidelines that we have at the hospital. And this will be available for the clinicians at the point of care so that we can improve both diagnostic stewardship as well as antimicrobial stewardship in our settings. So take-home message, the BioFire FilmArray tool is an adjunct. It's not a replacement of the traditional microbiology tools, because sometimes people feel that once you have this, it fixes all. No, it's an adjunct. It has several advantages: sensitivity, especially improved in viral infections, quick turnaround time, multiple pathogen detection. However, this must be tempered with sound clinical judgment, because not all organisms that are detected require treatment. I think that's the end. Thank you very much.
Thank you very much. We've had some extremely interesting talks, and I think we can have a few minutes of questions. If we could have seats put for our panelists in front, please. We'll allow about 10 minutes of questions. Who's covering the floor, please? Right. Is there somebody about to ask? I'll just give this to you guys and you can share it. Yes, Dr. Rossi?
Thank you for excellent presentations. I've really enjoyed them. This is to the infectious disease experts. It's very interesting to see how much we're picking from the BioFire, predominantly viral counterparts. So the question is, have we been over-treating so-called bacterial meningitis? Because we find, especially in the public hospitals, anyone who comes with classical signs, they're started on ceftaxone, 2 grams BD, the patient is not improving after 2-3 days, then we quickly throw in a cyclovir and hope, maybe perhaps. So the question is, and I'm really surprised to see there's, none of you actually showed any evidence of Neisseria meningitidis, and we've been teaching that in our school, so clearly it's good we are learning also as teachers. But one, are we advocating for BioFire from the outset? Is that what we are doing both from public and private? And if you're not having access to this BioFire, what would you recommend?
Okay, so I'll give my check and then I'll give Prof. So I think we follow the data. As you can see from our data, which is a predominantly HIV-infected population, the most common is crypto and TB, then viruses. Actually, bacteria are sort of lower down. And so in terms of the diagnostic pathway, and that's why I presented that algorithm. Remember that BioFire is quite expensive, and especially in the public sector, it will not be possible to expose everybody to BioFire. So knowing what our data says, then we go for CRAG, we go for GeneXpert. And if we eliminate those, then we can consider the next step as being BioFire. But going for BioFire upfront may be difficult. For patients who are not HIV infected, maybe the approach could be different, but I don't have much data in that population. Most of my cohort were actually HIV infected patients. So over to Prof.
Thank you. And the scenario you're talking about is what I saw over and over again in 2011 when I did spend a year at KNH. part of the problem was there was no cell count. The cell count could almost rule in or rule out pyogenic bacteria, and yet it wasn't available. So that's important. But it is true that HSV1 encephalitis, which is the one truly treatable virus that you would see across the spectrum, apart from CMV, VZV, which are primarily immunocompromised hosts, was being greatly overdiagnosed. And 1 day of acyclovir costs about as much as a CNS biofire, just to put that into perspective. Regarding TB, I don't think I would want it in the biofire because TB for the PCR to work well really needs to have about 10 mLs of CSF centrifuged and run. And I hope that in our lab we'll be able to put that together. But when you don't do it that way, the yield is fairly low, even with the gene expert. So trying to do it on that cartridge with a very small amount of CSF, I'm not sure would be productive.
Right, any other questions?
Yes, there is one at the back. Just comment on the TB. I think now AI is probably faster in diagnosing TB than gene expert. But I want to ask one question to the oncologists. How much are you developing virtual biopsy in the management of oncology in this country? And in the future, do you think there'll be any place for iKnife in the diagnosis of various oncologists?
Sorry, Prof. I didn't get the second part of the question very clearly.
The use of iKnife, surgical knife, in the diagnosis of tumor at operating table.
iKnife, okay. I may not be familiar with both concepts, but maybe what I can say is, by and large, there's been a lot of increase in use of technology, both even in biopsy and during operations, but I'm not quite clearly getting the second part of the, unless it's something I'm not aware about. What I know is knife, which is different. It's a form of a highly precise form of radiotherapy, which is meant to sort of mirror or give you the same outcome of having surgery. I think maybe I haven't understood the question well, sorry.
I think possibly the oncologists get diagnosed patients as opposed to, when you send them a patient, they say go and diagnose the tumor and then send them to us. So they may not do biopsies and so on. Dr. Murigi?
Thank you very much, Prof. There are some AI models for pathology diagnosis which are based on pattern recognition of the morphology of different cancers. I just don't think we have them here yet, but what we do have is kind of similar to what Andrew was saying, and I still consider this AI, but maybe the beginning, whereby we have digital pathology, where you can have slides prepared and projected on a digital platform for an expert to diagnose. So I know we certainly have that, but the technology where there are digital patterns, because Hodgkin's lymphoma looks like this, or prostate cancer looks like this, are certainly in development, but I don't think we have them here yet.
Thank you. So I'll take 2 more questions and then we'll close this session. Dr. Ross?
Let me just add something to Anne. The other thing which is now getting a lot of assistance with AI is the robotic surgery. Traditional robotic surgery would mean that there's a surgeon sat somewhere on a console and he's manipulating it's almost like a remote control, and then there are surgical arms that are in the patient performing the surgery. But now that process is already being overseen and being assisted by AI to improve the precision and to reduce the rates of complications.
Yes, Dr. Yosa?
Thank you very much. My question goes to the infectious disease team, especially the last speaker, and it's on the human cytomegalovirus meningoencephalitis. I'm sure you reviewed your old data and maybe with other centers. How does it compare? Because mostly we see it in advanced HIV, maybe yes, maybe mostly in the eyes, because in the brain, as you described, normally very fatal. How do you compare your data from the past and maybe other centers?
Thank you. So in our setting, we didn't have previous data simply because we didn't have the diagnostic capability. But from literature, we know that CMV tends to occur in advanced HIV disease, especially in those with the CD4 count less than 50. And in our cohort of patients, that's actually what we saw, that patients presenting to us ART naive, advanced immunosuppression, these are the ones that we are finding CMV disease. And it also tends to occur with crypto, and that makes the diagnosis a bit difficult, and even the treatment, because now it's going to be targeted to both fungi as well as the virus, and the treatment is also prolonged. So I think these are just new frontiers that we are getting into, understanding the epidemiology of meningitis within our setting, and especially in patients with severe HIV disease. So it's an eye-opener.
Okay, final question,
thank you.
yes?
Thank you to the speakers just behind Dr. Yosa. My name is Dr. Kamodo. So first of all, so thank you to Dr. Mwirigi for that reminder of the connection between low B12 serum levels and thrombosis. That is quite a good reminder there related to the hyperhomocystinemia. But mainly to the two gentlemen who talked about the infectious diseases. Professor Adam Amondio left a little bit. And I'm asking about the outbreak of meningococcal meningitis in the UK. There's been an outbreak recently in Kent, and your particular type of clientele may be more prone to traveling to the UK. Have you come across any, and what comment might you have about that particular outbreak? It's true that it's meningococcal type B rather than the A and C that we see over in Africa. And on a similar note to Dr. Kwoba, it's interesting that you did not come up with any results. There was no positive results in your study on meningococcus, if I got you correctly. That's an interesting finding, and what do you comment about that?
Okay, regarding the Kent outbreak, I think that's a bit unusual, but still fits within the pattern of seeing it in close quarters, dormitories, military barracks, and the like. In terms of not seeing it here, it's not just from the CSF biofire, it's from long before then, not having had, we have about a 15+ year record from Vitek data for microbial identification, and there weren't any invasive Neisseria meningitidis cases there. So that would have been from blood culture. So I think overall, it's a very uncommon infection here. And in fact, even the one that was seen recently at our institution came from elsewhere. But apart from it being unusual, I can't comment about why.
Dr. Kwoba, did you want to answer?
Yeah, so I think meningococcal disease also tends to occur in epidemics. In our cohort, the major driver was immunosuppression, HIV. And that's why we are seeing, TB, crypto, viruses, and not really bacterial disease. And that may explain why we're not really seeing a lot of meningococcal disease, simply because this cohort, over 80% were HIV infected. And probably also epidemiologically, it seems that meningococcal is not as common as we thought now that we have better diagnostic tools. So that's what I would say.
Right, thank you very much. We've had a very exciting session. I've learned that I need to look at something called RDW in a full blood count panel. I've learned that there's Cloud or Claude that I need to get to grapple with. And I kind of have an idea, a vague idea of where BioFire will fit in the management of my patients. I'd like us to thank this panel for a fantastic job. Let's give them a good hand clap. Thank you. Session closed.
Another round of applause for esteemed faculty from infectious disease, oncology, our excellent chair and moderator for such a lovely session. I'm kindly requesting, this is the most quorum we have ever had in anticipation of an AGM. So I'm going to defer the tea for like about an hour so that I can hand over to President of KP so that we can, since we actually do have quorum, if we could just proceed with the AGM, right? Right before I release you to go and have a lovely dinner. Now, our dinner is actually sponsored. We are broke in KP. So what we do in our spare time as officials is we smile at certain sponsors. Our current sponsors, I'm waiting for the president to come and introduce them. As we are waiting, please don't walk out. I promise we will give you tea. Otherwise, I want the president to first do a teaser to make people stretch. Then you can introduce our last talk before we start our AGM. So, I want to wake you up a little bit, okay? So I want everyone to stand. Don't worry, you're not going to do anything heavy lifting because even me, I can't stretch. But Eric, you're the one who's supposed to come and do the stretches. I want to see how well your coordination is. You don't stand and pick up your bag. By the way, we'll fine you. We will not give you dinner vouchers. If you walk, even those ones who are refusing to look behind. I want you to put your hand, the right hand, on top of your head. And then the left hand on top of your stomach. I want you to rub your right hand clockwise and the left anti-clockwise and see if you can actually manage. No, one clockwise, the other one anti-clockwise. Faster. Okay, now switch. Switch clockwise, anti-clockwise, the other direction. No, now switch back to what you had started. Then now switch again. Where we are at? Okay, now the person who is next to you, I want you to observe what they're going to do. You can only sit down, okay? If you've ever experienced one of these, you have sent an interesting message to the wrong WhatsApp group. You can sit down. Really? You've never sent a message to a wrong WhatsApp group? Yes, I know we're starting to see. You have walked out of a conference when it was just getting interesting. There are many defaulters, my God, really? You have let your phone ring while you are in a conference. Whoever remains standing is actually going to get a gift. If you can be able to guess the last 3 emojis that the person who's sitting next to you sent in the past 24 hours. When you guys don't sit next to each other. Okay, I'm done.
Thank you, everyone. So I think what we've agreed with our sponsors is they can just do the talk after the AGM so that we can promptly save on time. I think it's 5:30. So we have 2 sponsors for the dinner. We have Mivida Homes, and please, you can visit their booths. And also we have Jubilee, who have their new international scheme called Allianz. So Jubilee will present, and also Mivida Homes will present. So I think we can quickly start the AGM, and our audiovisual team, it's a hybrid AGM. So we'll have also the people who are not here physically will also attend and log in online. So let's just have the agenda projected. And probably we don't need to sit all the way at the back. Let's occupy these seats there's a lot of spaces here at the beginning. I can see you, Nicola, Jackie. You guys move forward. Yeah, so the guys at the very back rows, just please can you move forward. Let's have the agenda put up.